Now it's my pleasure to introduce today's speaker, Dr. David Henderson. Dr. Henderson received his undergraduate degree from Tufts University, and the most important thing on his CV, his MD from UMass Chan Medical School. Well, it wasn't Chan at the time, but it was UMass Medical School, and he just said, "Oh, you got a new building." After graduating from UMass, Dr. Henderson did his internship at St. E's in Brighton, and then his psychiatry residency at MGH, where he was the chief resident in psychiatry in his last year. Dr. Henderson currently serves as Psychiatrist-in-Chief at Boston Medical Center and Professor and Chair of the Department of Psychiatry at Boston University Chobanian and Avedisian School of Medicine. He is also the co-founder and co-director of the Africa Global Mental Health Institute. Dr. Henderson previously served as director of the Chester Pierce MD Division of Global Psychiatry at MGH. He was the director of the MGH Schizophrenia Clinical and Research Program and medical director of the Harvard Program in Refugee Trauma. Dr. Henderson currently serves as co-director of the NIMH T32 Boston University School of Medicine and Mass General Hospital Mental Health Clinical Research Fellowship. He has worked internationally for the past 30 years in resource-limited settings in areas impacted by mass violence, disasters, and complex emergencies. He has conducted research and training programs in Bosnia, Cambodia, East Timor, Ethiopia, Haiti, Liberia, New Orleans, New York City, Rwanda, Peru, South Africa, and Somaliland, among other places. His work consists of field studies, needs assessments, mental health policy development and strategic planning, quantitative and qualitative surveys, mental health capacity building programs for specialized and primary health professionals, and skill transfer program evaluation. In the United States, he has conducted more than 30 randomized clinical trials in severely mentally ill populations. Dr. Henderson has mentored trainees and junior faculty who have progressed to K Awards, including some of our own faculty now here, and secured other independent funding. He is also a director of the American Board of Psychiatry and Neurology. And if we could have the next slide, please. Well, while we're doing that, the title of Dr. Henderson's talk is "The Best Boston Model for Decriminalizing Mental Illness." Let's give a warm welcome, please, to Dr. Henderson.
Wow, thank you so much. It's great to be back. I love coming out here. I even love the drive down the Mass Pike, and it reminds me of my medical school days. In my fourth year of medical school, I moved from Worcester back to Boston and did the reverse commute. And so I remember that drive very well. So I'm going to talk about the best model, not the best or the greatest, but the Boston Emergency Services Team model for decriminalizing mental illness. And you know, this is I'll tell you a story that how I became interested in this. As you know, we've always in Boston, there's always been the best team, the emergency services team, the mobile units, and so on. When I moved from Mass General to Boston Medical Center in 2015, I didn't know at the time, but Boston Medical Center ran the BEST program for the region. And I didn't know that at the time. I knew of it, but I didn't know that Boston Medical Center ran it. So I asked us a very simple question to the leaders of the program, send me the papers from, you've been, this program's been going for 15 years. Send me the papers about it. And so, I'd love to see how we can do things differently. And they all looked at me kind of strangely saying, and then finally someone said, well, we send a yearly report to the state. Is that what you want? I'm like, no, I want the publications. Like, no, there are no publications. And I said, send me the reports. And the reports were all just like bean counting, number of people, that sort of stuff. But I thought about it like, we do all of this clinical work, and this is really happening all over in healthcare and in industry, where you're getting access to records and you can use that data to, ask and answer questions and learn. And this particular area was vitally important for us to learn from. These are my disclosures. Now, one of the things that was unique going from Mass General to Boston Medical Center is that the population that I was treating or that came to the hospital was drastically different. At MGH, and people know MGH, and we've got people who trained at MGH, we know that the population was, at the time that we trained, probably 95% white that went through the building. However, at Boston Medical Center, 70% of the people identified as people of color, which means that it was just very different population, even though the hospitals are just 2 miles apart, but very, very different population. So not only were we culturally diverse, but there were also economic diversity, language diversity, and so on. And we also knew that, there were some inequities in health outcomes related to our patients. And so at the hospital, and it's now been in its like 4th year or 5th year, we started this group called the Health Equity Accelerator. And basically, we started focusing on inequalities in healthcare and our own outcomes at the hospital. Like, why would our outcomes for a population be different than the outcomes at Mass General or the city in the region and that sort of stuff? So we started to look at our own data. And I think if there's anything that I want to emphasize today is that it's about the data. Looking at and using the data to inform us as to what we need to do next, or what we're missing, or how do we improve, or what we need to improve. But anyway, we were under the assumption, for instance, well, our patients are 70% non-white, our staff and faculty are very diverse, so we should be treating people equally well, right? We should be, we really shouldn't be finding things. I said, well, let's look at our restraints, because our residents are telling us that our Black patients are restrained more than other patients. So let's look and see if that is true. And it turns out, yes, our Black and brown patients were being restrained in our own emergency room more than the white patients. And so then we had to work backwards to try to figure out, well, why is that? Because we're all, quote, multiculturally trained, and we've experienced all patients, all different populations. But how is that impacting our decisions? And it turns out it was a systems issue. And this is one of the things where we had to first look at the data, then do qualitative study, and then we got to the answers. The patients were telling us the answers. Oh, well, I didn't see a doctor. They restrained me before I even made it to a room. I was put in restraints. So the high rates of restraints were happening before our psychiatrists and psychiatry residents, whatever, had a chance to evaluate the patients. And so there we, and it was, so we had to develop interventions and change protocols in order to, reduce that. But it really is important to pay attention to that. And then with COVID, everything was magnified. The disparities within our system were just magnified with who got COVID and then who got hospitalized and even death outcomes in the early days of COVID. So we knew that and I'm not sure if you went through this here, but at one phase where it was the peak of COVID and hospitalizations and deaths, yet we didn't have and we didn't have the vaccine yet. and we were running out of respirators. And we were down to 2 respirators in the hospital. And so we had a team of people that had to, put together a model to determine who gets the respirator. We had 2 left, people would cycle off and go up to 3, sometimes down to 1, but we were at this critical moment where in this country, we rarely have to do, in many other countries, they do all the time. We had to decide who lives and who dies based on availability of equipment. And so they went through this models, and then we ran the models to see, and it was like every time we ran the model, like all the Black patients died. All the Black patients did not get the respirators. And the reason is, it was very simple, because we use what has been in the literature and that sort of stuff. But if you're Black and you've got COVID and you've got, lack of resources and you've got longstanding hypertension, you've got a bunch of disorders that comes with that is counted multiple times in the risk model. And so with that, every time the Black person would not get the respirator. And so we actually had to go and develop our own that leveled the playing field and not penalize for things that come with that experience of being Black in Boston with lack of resources and so on. And so we went through all of that. But again, if you don't do the exercise and if you don't think that way, you're just making decisions, but it's impacting people's lives. And the good news is that we never had to trigger that program, but because we were always teetering on one. We're down to 1 or 2, but we never got down to 0. But we had lots of discussions and heated discussions about this, and so health equity is the absence of avoidable, unfair, and remediable differences in health outcomes among groups of people. And it's a bunch of issues that we have to consider: economic, race and ethnicity, language, behavioral health. But we identified a bunch of trends that all fit together, that were just feeding each other, whether it's the high disease prevalence, poor experiences within the health system, lower trust in the system, and feeling of disrespect, more likely to no-show, lower screen rates and med adherence, and on and on. There were so many factors that impacted patients' outcomes, and where we would lose patients. I mean, they wouldn't come back. They'd fall out of treatment and that sort of stuff, because there was just so many barriers in place. And we really had to start to think about this in a systematic way versus this is what we do, and we expect people to show up. If they don't show up, then it's their fault. But actually, it turns out we were part of the reasons that they weren't showing up, and we really needed to understand that. And so, BMC has always been a clinical place where they pilot programs, and it's actually really cool. I tell this story to folks, like when I was at Mass General, we would, let's say, the chair would call me into the office and say, "Hey, I want you to start a program in psychoclimatology." And I'm like, "Okay, that was good, thank you." Walk out, I'm like, "What is psychoclimatology?" I have no idea. The next day, in the Boston Globe, MGH launches a program in psychoclimatology, and I still don't know what it is. I'm learning about what it is from the Globe, and then eventually we start a program in psychoclimatology. We get it, right? But MGH has already staked this claim We're the top program in the country in psychoclimatology now. And this is a true story. And you go to Boston Medical Center because they have always been about how do we do the best for the community stuff. And so you discover they've been doing psychoclimatology for 20 years and just never told a single person outside the institution about it. And that's like the difference between, but what they didn't do well, they've started all of these innovative programs. They never evaluated them. They never looked at the data. And so as I was interviewing to take the job, I'm like, there's gold lying around everywhere and they don't even know it. Like all of these amazing programs with, outpatient assisted, treatment for substance use and just, programs for economic mobility and housing and, gunshot victims and just a whole bunch of stuff never evaluated. And so we took this and then we moved it towards we need to do research in everything that we do. And we certainly need to evaluate everything that we do because we could learn quite a bit. And that data can then help influence, policy and advocacy and so on. So as we looked at our data, we just found these huge gaps. Mother and child, infant mortality, Black infant mortality 4 times out of white infants. And even in behavioral health, Black residents 1.5 times more likely to suffer from persistent sadness and 2 times more likely to attempt suicide in our system. Black residents 5 times more likely to experience homelessness. So we knew that there's just disparities everywhere, and that we had to really do this in a systematic sort of way, and that's I think what we set out to do overall. Now I'm going to flash back to early in my career. I actually was interested in the criminal histories of patients with severe mental illness, and I did a paper with at that time a resident, Gordon Frankel, and we wanted to look at clozapine because I was impressed that just by observation that when I put patients on clozapine, that like their criminal involvement just disappeared. It just stopped. And so we did a study to look at that, retrospective study, and we got the CORIs, the criminal records of every bunch of patients, 168, I think, or something. And 165, and we were able to show that putting a patient on clozapine dramatically reduced arrests. And I thought, wow, this is like, really cool. And then, of course, moved on to something else. But in other words, we know there's a challenge with patients with mental illness, and that their involvement in the criminal justice system is way too high. But we found something that actually reduced the rates of arrests. And as you can imagine, oftentimes patients, they're arrested for really minor stuff, trespassing in their parents' home or, urinating in public and that sort of stuff. But but those small arrests and even the occasional big arrests actually, resolved with patients doing well on clozapine. And the criminal justice system, as you know, has become a huge part of the mental health system. Both the police and criminal justice system at large do not have the knowledge, training, and expertise as mental health professionals, and should not be the first responders for most situations. So we had a challenge, and then we know that patients with mental illness, particularly severe mental illness, spend a lot of time in jail and in prisons and stuff, and so and they cycle in and out repeatedly, in and out, in and out, in and out, but there were multiple entries into how they get there. Right, it starts with the police, and And we thought about, there's multiple ways to intervene or to prevent or divert and so on. And so I'm going to talk about our emergency services program that started just as a mobile unit, but expanded to touch upon some of these other entities. The national crisis. We know that way too many patients with mental illness are in jails. And then, of course, you always, every few months, there's an article in, a paper and stuff about someone with mental illness receiving poor care in the jail or prison system and having a bad outcome. It's pretty common. We know that people with mental illness are overrepresented in the jails around the country. And then there's lots of factors that are driving this crisis. Higher rates of arrest, limited access to healthcare, lower utilization of evidence-based practices, longer stays in jail, higher recidivism rates, and more criminogenic risk factors. So lots of factors are contributing to this. And there's a nice report from the Council of State Government Justice. For instance, like detaining low-risk defendants, even for just a few days, is strongly correlated with higher rates of new criminal activity. So somebody gets arrested, they're in jail, just for a few days, that increases their risk of doing something else when they get out. Just a few days. Low-risk defendants had 40% higher chance of committing new crime before trial when held 2 to 3 days compared to those held 1 day or less, and 51% higher chance of committing a new crime in the next 2 years when held 8 to 14 days. So the longer they're there, the greater the risk. So the challenges that counties and communities face is that it's a multi-system problem. It's law enforcement, it's courts, it's probation, and it's behavioral health. And I'd say behavioral health and really health in general. So multiple factors and multiple problems. Now, there's been some, reports, and there's a nice book that came out last year, I think, about decriminalizing mental illness. Very thorough. But we know that we have to fix this system. And people have done a bunch of different projects and stuff. But I think that one of the challenges is that people focus on one slice of the problem, one piece of the puzzle. And they have good outcomes. Oh, that people get better, people, whatever. But there are multiple areas that are problematic that we need to focus on. It's recommended there should be community responder programs and mobile units, paired with physical health professionals, like with paramedics, working with the 911 calls. So there's a number of things that could be done. And so the goals are to reduce the number of people who have mental illness booked into jails, shorten the length of stay in the jails for people who have mental illness, increase connection to treatment for people who have mental illness, and reduce recidivism rates for people with mental illness. So those are the objectives. Now, I show this slide because, as you know, in the media, every few months or weeks or whatever, something bad happens, and it's shown like with somebody with mental illness, and it's displayed like this is someone, I think in Philadelphia, a person with, I think, bipolar disorder or schizophrenia. And in this situation, they put a bag over his head. And I didn't know that was actually common practice. They think maybe it helps him stop yelling or whatever, but for whatever reason, this young man died during this intervention by the police. And here's another example of someone with bipolar disorder that the police had come and visited him like just 2 or 3 hours prior and left. And they got called again by his mother saying he's still, wild and so on. And he has a knife in his hand and they shot him like multiple times. Now, he wasn't charging at them. They were charging at him. They were moving towards him and they shot him. And then, of course, this is, all around like the George Floyd situation. And I had an experience, a personal experience, that kind of helped trigger some additional thoughts for me. But it was during COVID, a lot of attention on George Floyd and so on. And I had people calling me like, Dave, what do we do? And I'm like, why are you asking me? I don't know what to do. Like, tell them to stop doing it. I have no idea what to do. And then I had an experience where I went to the grocery store. I went to a town next to where I lived. I went to a market basket and got my groceries, came out. I was putting my groceries in the trunk. And I saw maybe 20 yards away from me, there was a police car and a police officer, and the lights were flashing. And I guess he had stopped a young white male, and he was searching the kid's trunk, And then he called for backup, obviously, because another police car started coming in to the parking lot, flying in, lights flashing and everything. And he had a direct line to where that police car was and where the other police officer was. A direct line. And he somehow saw me. They're here, and I'm over here. He somehow saw me with my trunk open, putting my groceries in, and totally deviated and pulled up right next to me. And I looked at him like, what are you, an idiot? Like, your guy needs help over there, and I thought to myself, how powerful is that, right? Like, for his brain to tell him, like, I'm headed right for my partner there that needs help, but that's where the danger is. How powerful was that? And he couldn't stop himself, right? You're like, I had the thought, oh man, look at that, I better go help my partner. I thought, wow, so these folks need help. They need help. And then, I processed that, multiple times with multiple people. And then I woke up at like 3 a.m. And sometimes I have my best ideas at 3 a.m. for whatever reason. I wake up, I look at the clock, it's 3 a.m. Time for an idea. And I realized that, wait a minute. We actually, in our work at Boston Medical Center and what we're doing, we actually have the opportunity to have an impact. As I'm going to describe, like, many of those challenges that I talked about, like, we're actually touching all of those systems. We have programs. I'll describe. We have a police ride, a co-responder program with ambulance co-responder. We got a, mental health court. We've got, we have all of those entities. We need to bring a level of multiculturalism to this and to give them opportunities to make different decisions, both about, mental health, but also racial and cultural and ethnic differences as well. We need to give them opportunities to make different decisions. So I'm going to describe this model, and I have to look at the time because I've got a bunch more slides that show data, but oftentimes I never make it past this slide because it really tells the story. So it started as our just the BEST program, the emergency services team it had a mobile unit, would go out to people's homes, evaluate them, would go to emergency rooms and divert care. But what I decided to do, and I have nothing to do with any of these programs really, like we support them and such, but I'm not running the programs, not my ideas. The ideas came from the data often, but decided that we have to first take our emergency services data and turn it into a research database. And at that time, it was 15 years. Now it's like 20 something years of data. We're at about 120,000 lives in this database. The majority are just one encounter, many also with multiple encounters, all in acute distress. So we started doing, it took, several years to get all the approvals from the state and that sort of stuff to use this data in this way. But we started, analyzing and making and getting publications and identifying, like I thought, I'm a psychosis person. I'm like, oh, it's psychosis driving much of the work. It turns out it was mood disorders, mood and anxiety, which would lead us to think that we can do something very different as well. It's not, the psychotic patients out of control that are using the services. They were second in line, but the first was like 40-something%. It was mood disorders, mood and anxiety. So we learned from that. But after the BEST program was launched many years ago, we added a police co-responder program. And it started with we had 2 clinicians that were available to ride out, when there was a clear, mental health issue that 911 was called for. We had clinicians that could ride out with the police officers and help doing the intervention and so on. And now the police, would lead it because, they first had to determine safety. But oftentimes we were able to divert people from being arrested when there was, plenty of activity that could have normally would have resulted in them being arrested. So after George Floyd and everybody was calling for police reform, we were contacted by the city of Boston and asked if we could expand our program. So we went from 2 clinicians to 20, and we have a clinician in every precinct, and then the city of Brookline came and they wanted it, and then another city, and so we have several programs. All in all, this is great, and we're collecting our data, and so we started to work with these entities to not only do the intervention, but to share data and connect the data. So at the end of this, the story is going to be that we're connecting our emergency services data with health plan data, with police data, with court data, with probation officer data, even in with school data. We want to be able to follow patients through these paths so we can figure out how can we change their course or their outcome. So from that, we went on to establish a mental health and substance use court with 2 courts in Boston. And again, if they, so we're trying to get them when there's the police interaction. We're trying to have an impact there, and then we're trying to have an impact if they end up getting arrested. We're trying to have an impact on the court system. Now, oftentimes, we were able to have the police, if they had to arrest the person, they just couldn't, let it go, to make it a citation, and then they would show up into court as opposed to handcuffing them, taking them to jail, and then so on. Because oftentimes, if one of our patients got arrested and in jail, they could spend weeks or months there because they don't have the $25 to get themselves out. something as minimum as that. And so now we have the police. Now we have the mental health court. Actually, yeah, we have the three courts, and then we added. I identified the problem where when there's a problem if people don't get connected to healthcare within a month of coming out of jails, they're likely to end up back in jail. And so we added we got a grant, I think SAMHSA grant to pilot an outpatient assisted treatment program so that we got people, as they were ready to get out of jail, we were able to connect them to healthcare and mental health care in particular. And then we added a both outpatient treatment program where we could deliver care for psychotic patients and substance use patients. We could deliver care in their homes. So kind of reducing the barriers. And I think that, one of the barriers is always like we're a healthcare system and we set up programs and we have policies and so on, and patients don't adhere to that. We call them a bad patient and that sort of stuff. But my challenge is, and I tell this to our residents all the time, like, how do you set up a mental health system that cares for people from 70 different countries every day? You know what I mean? Like, we expect them to line up into our plan and program and to engage, like, your appointment is at 8:10, you arrived at 8:15, you cannot be seen. You will have to be rescheduled. Where from the country they were from, when you go to the doctor, you pack up the family and you just plan to hang out and spend until it's your time to be called and that sort of stuff. But we want them to be here precisely at this time, and then we penalize them when they show up a little bit late and that sort of stuff. So anyway, it is a challenge for us to expect our patients to fit within our system, particularly when they've, from other countries and had other experiences and that sort of stuff. And so, like, well, why is our no-show rate like 20, 25, 30%? Well, like, what are we not doing? What are we not asking? Just a very clear example. We have, Boston Medical Center is great because you can get substance abuse treatment anywhere in the hospital. Like, every department has you can get Suboxone or, whatever in any department, which is pretty amazing. It's pretty impressive. But when we were looking at the data, it showed that, like, what comes to the emergency room, from a substance abuse issue, it represents the demographics of our patient population, 70% non-white. And when we looked at our outpatient programs, substance use programs, it was 70% white. And I kept asking the question, why? And everybody told me, in every department, oh, that's the way it is nationally. Yeah, but why? Why is it such? And then finally, we started to do, not just we got the data, but we started to do qualitative studies to ask patients, why? Let's ask the patient. The patients will tell us, and they did. It turns out, for the Black patients and many patients of color, what we were offering, they didn't want. We never asked them, how do you want to work? How do you want to deal with this problem? What help do you need? For our Black patients, it was like, all they do is talking about take another drug or something. Like, then I'll be like a drug addict. Like, I want a counselor. You got a counselor? Well, we weren't offering counselors. We were offering, harm reduction, Suboxone to every person and that sort of stuff. And all we had to do was ask the patients. So it's critical. So now we have all of these services, and then we realize we're still missing one. So we're getting them, we're with the police, we're working with the police, and then we got a pilot thing, and now it's permanent that we interface with 911. Our emergency services clinicians, our call center interfaces with 911 and now 988. So we can be on the phone listening to it and helping them triage, which I think is very, very important. And then the state changed the regulations and so on, and so where sometimes ambulances can just go out by themselves and that sort of stuff. So now we have a program with the Boston EMS where our clinician can ride out with them and evaluate. So you actually have a master's level clinician evaluating whether the person needs to be brought to the emergency room or not. And then the final piece we just added, it's not on this slide, but we just added, we were approached by the Suffolk County Jail's office. And so there's a Nashua Street Jail, one of the largest jails in Boston. So now we've just opened a mental health clinic in the jails. Staffed 16 hours a day, so that we can get patients well, get to good outcomes, and then connect them to services as they are being released, but also advocate for their release. And if they just can pay $25, and we can connect them with organizations that would do that, and so on. And so that's like it's probably not the final piece, but the data will show that it's this is a key component. And so with all this together, we brought in our multicultural training group. So, and I think there used to be a program here at UMass in multicultural psychology years ago, but so we've had this multicultural psychology group for 50 years at Boston Medical Center, and they're experts in multiculturalism, and they, this is what they do, and they, we have, I think 10, psychology interns and maybe 4 to 6 postdocs, and they're just good at what they do. So we decided that, it turns out that we, once or twice a year, we teach the police. We have a program to teach them about mental health. We have the same thing with, with the courts. We have the same things in the schools. And so we decided that we're going to bring multiculturalism and lay it over top of all of our programs. First, to make sure that our clinicians, are skilled at understanding people's diverse backgrounds and how it impacts decisions and so on. And then we're going to integrate that into what we do with all of these other programs with, as I said, the police, the courts and so on. And even the schools, we started working with the schools, and it was interesting. We started looking at the youth data from the emergency services, like when are we asked to respond? And then what are the outcomes and stuff? And it turns out that there were really 2 schools in Boston that would call us, and then they would call the police. And so the police would arrive before we got there, and sometimes handcuffing these kids, taking them to emergency rooms or whatever. But the data allowed us to identify, and then we went to the schools to ask the questions like, what is your protocol? What is your process? And it turns out that if we didn't get a clinician out there within an hour, they'd call the police. And so now this young kid is now entering into a totally different system. And so we went to the city of Boston and we talked and we shared the data. And then they they have a social worker now, and this is doing, after COVID and stuff, they have a social worker now in every school that's connected to our program. And so if there's an escalation that's required, we can get our people out there before they turn to the police. So again, for me, it's all about using the data to understand what is happening, where we think that we can do it visually and observationally and stuff, but let the data tell us, what are we doing? What are our problems? And then, developing programs to address it. And people ask me, well, how is this all funded? And some of it is services contract, like the emergency services team. That's a, mass health services contract. Some of it is from the city of Boston, the ride-along programs, or other cities like Brookline. Some of it is from the state itself, like the mental health court. Some of it is through grants like SAMHSA, HRSA, and we get the grants because we have the data, and so on. So it's a combination of funding sources, but what happens is that usually, when you're showing outcome, for instance, in our police ride-along program, our co-responder program, we reduce rates by, arrests by 75%. So when we take that back to the city, then these grants, or whatever you call them, they just rolled over year after year. So anyway. So that's the bulk of the story. As I said, I usually have like a bunch of slides that I'm not going to show, but it really is, this comprehensive program. And then of course, we thought we had like a good system and things are working well. And then the state launches the CBHC, right? UMass is a CBHC, right? Is that, yeah? And it disrupted everything. I'm not sure what it's been like for you. We've had a hell of a time in Boston. Part of it is the CBHC, it has so many requirements. It's very expensive. But it was rolled out without data, without we looked at the data, and data showed this is where we need to target and that sort of stuff. They didn't do that exactly. They just rolled it out. And so our utilization is like 50% of our capacity. And then the other thing it did, it disrupted our best team, our emergency services team, because utilization went down to a third of what it used to be. So it led to some huge financial problems, which is yet to be figured out. Now, so we've done a bunch of studies, and I want to leave some time for questions. And there's a bunch of papers that have now come out using the data. And what is so cool about where we are in science-wise with big data sets is that we're merging data sets. As I said, we're bringing all the data entities together, but we're also able to, in this case, like our first project, Dr. Oblath has gotten a R34, I think, to overlay climate data on top of our data, our emergency services data. And so the question is, are there changes in behavior or in utilization doing climate change. You know, we're looking at extreme temperatures, highs, lows. That's the first thing. But then we can also look at neighborhoods like green space. How many liquor stores do you have in your neighborhood? Like, there are some neighborhoods in Boston that have like 10 times more liquor stores than they have like grocery stores or even convenience stores. Like, how does that impact what happens in the utilizations of emergency services and so on? And so it's a really cool thing because we're learning as we go and we develop programs, and people say, well, how did you come up with this? It's like, it was done piecemeal. You know, it was done like, oh, wow, there's a huge gap here. We need to try to get this program, or we need to do that. You know, there was no master plan. It was just simply done because we recognized the need, and sometimes it was because the data helped us recognize that need, and so anyway, I'm gonna stop so there's some time for questions. If anybody wants this slide deck, I'm happy to send it to you. It describes some of the studies that we've done, and so on. But I think the story is more important than the actual manuscripts or papers. But because when I've talked to other people, and I am no expert in decriminalizing mental illness, but there are people in the country who are experts in it. But most programs simply, work with one entity and stuff. They're not looking at all of the places, where things can go wrong, and then our patient ends up in jail. So this is a much more accidental, comprehensive program that has come out of Boston. So I'll stop here and see if we have some time for some questions.
Questions? Questions?
Thanks so much for that talk. I love the piece about the data kind of leading you where to go, but I'm going to ask you a question upstream of that.
Yeah.
When you have all of these different service lines, when you have all of these different places with limited resources, how do you best get that data and know that you can rely on it? Do you have a secret for how to help acquire all of that data?
Yes. Acquiring the data. How do we acquire the data? Relationships. It's about relationships. So we had our data, and again, I had to do some legal stuff for us to be able to turn that into a research database. But then the others, it was simply about relationships. Like the police, we were collecting, our clinician was collecting data. We had that, but we didn't have the police perspective, right? And they were never going to give us that data. Until we started meeting monthly. So we got the police in the room, the judges in the room, folks from schools, and we started meeting monthly over like 2 or 3 years, like really. And then, now they're at the point where they're ready to share their data. We have to have agreements and that sort of stuff, but it was purely about relationships, nothing more than that. Thank you.
Other questions?
Thank you. I have a question about who may or may not be in the slide with the different bubbles. Do you have peer recovery support specialists on the teams at all? So folks who have lived experience with either the criminal legal system and or substance use disorder or mental health?
Yeah, that's a great question. Yeah. First is that we have and this is also one of those programs that's been funded for 20 plus years. We have one, and it's probably one in Worcester too, but a recovery learning center where we have a training program for peer specialists and so on. And so in all of our programs, we utilize peer specialists, both in mental health, substance use, and in all of our grants that we write now, there's involvement. And plus, what's also nice is that the state has allowed some of their work to be reimbursable as well, which is great. People before it was, we would have to get a donor or something to support that, but now they're actually generate some revenue. But I think it's really important, and that's what the point about like our Black patients. That's what they wanted, like a counselor or peer coach or whatever. They didn't want Suboxone, and so we believe we can connect with groups better utilizing this service. And I think you have a program like this here. Is that right, or at UMass? Do you have?
I'm not sure in terms of peer recovery support specialists, but there is the Everyday Miracles is on Park Ave. It's a recovery community center. That's what you do in Boston.
Okay.
We have a question online. It's a long question, so I'll try and read it quickly. It looks like an important question. So the questioner says, Black people in the United States are significantly more likely than white people to report having had serious psychological distress just from systemic racism alone. It's thus more likely to attract heightened police scrutiny and reasonable suspicion. They are less likely to respond to police in ways that comport with police behavioral expectations, thus prompting unfortunate police escalation. The concern is the way people of color who may not be noticeably mentally impaired or who might suffer from episodic or latent mental illness can be provoked into a state of mental illness through brutalizing police encounters. As a provider of color who bears witness to the failings of the U.S. mental health emergency response system, here's the question. How do we best, quote, reluctantly, unquote, counsel our patients to trust the system, though we're fully aware that it may harm them rather than ensure their safety?
Wow. Yeah, that's a good one. I think that, the first is like I've had conversation with my kids, driving while Black sort of thing, right? There's advice that you could give that allows a situation not to escalate. Like we saw, just 2 weeks ago, football player, even I think one of the Patriots players, like escalated the situation. He got pulled over by the police, and all of that history came up, right, at that moment, and was involved in the escalation. The police escalated too. Like there was, each could have stopped it at some point, but in fact it just escalated. So the one thing is, you tell patients, like it's not going to do you any good. It's not going to you're not going to improve your outcome by yelling at the police or this or that sort of stuff. Your best way out of it is just to remain calm. That's what I tell my kids. Like, don't, just answer yes, no, give your ID, be done, that sort of stuff. But the flip side is that the police are not supposed to escalate situations, but they do all the time. They feel disrespected. They feel this, they feel that. And that's why what I'm talking about is that we have an opportunity to work with the police to give them the ability to make different decisions. And one of those is to not escalate situations or stop before you have to shoot when the person poses minimum threat to you or that sort of stuff. So it's not easy, but in a situation where you're encountering the police, like you're absolutely right about the history, and they may be targeting you and that sort of stuff. But to get out of the situation, yelling and becoming combative is not is not a great route to get to where you want to get to.
Well, we've gone past the hour, but if you can hang around, if you have time for questions, I don't know. But thank you very much. It was very interesting talk.
Thank you.